Emily Kumler, and this is Empowered Health. This week on Empowered Health, we're going to be talking about diabetes. This is a really important topic because I don't think that most people realize that 50% of Americans right now have diabetes or have pre-diabetes. This is costing the country more than $300 billion. That's billion with a B in care. And it's possible that people don't even need medicine for this. Everybody's been diagnosed with these diseases, gets put on insulin. And there's a company called Virta Health that's been looking at this problem and figuring out that maybe by changing things in your diet, you can control your blood sugar enough that you don't need any outside insulin or other medications. Okay, so we're going to start off by talking to one of the first patients in the Virta trial. Here is Kim Shepard. She's 58. Do you remember how much money you were spending on medications?
It was about $158 a month. I'm off of 10 prescription medications in this 3-year study. And that doesn't even count the Trujillo because I was not paying for that. I was still using the doctor's sample pens, but I did call my pharmacy to see how much it would be. And it was $258 a pen. And where I had gotten to in that point, I was on 2 pens a month. So we're talking about almost tripling my prescription costs had I had to stay on the Trujillo.
So you saw an ad in the newspaper for the Virta study, and do you remember what it said?
It's a diabetes study. I'd been on that Trujillo pen about a month, maybe 6 weeks. It was miserable. I mean, you're sticking your stomach, you're injecting the pen right into your stomach. So then you lean against something, your stomach is tender. It was just miserable. And I just thought, I can't do this. And my uncle's a diabetic and he's always an insulin taking diabetic. And I would see him at family parties having to measure how much insulin he needs. And I was projecting myself into that future. And I just thought, I can't do this. I saw the study and it was, they were doing 200 remote. I'm in Indianapolis, so I was in the remote and it was in Lafayette. So I went up to Lafayette. It's an hour, 30-minute drive from Indy to just talk to Dr. Hallberg, see what this was about. And she gave me encouragement. Honestly, it's the first health encouragement I've probably had in 10 years. And I was 328 pounds and still had a 268 fasting blood sugar. But her enthusiasm for the project gave me hope and how that worked in the study. So you get your stuff and we have a scale and it goes up into the cloud. It's magic. You don't even have to look at the scale if you don't want. They said when you onboard into the program, into the food part, and that's all it is food. She took me immediately that very first week off of the Trujillo. I stopped taking it and I asked her, I'm like, my doctor at home said I'm no longer producing insulin. So how's this going to work? And she's like, trust me. I'm like, okay. She gave me hope.
That's a lot of trust, right? Like that sort of sounds terrifying in a way.
It was. And I'm an hour, 20 minutes away from her office. So, I was like, okay, I'm going to go with this. They'd had some people that had already been in the study. So that was in the newspaper. One guy had gone off his meds and he was doing great. And at this point, I'm willing to grasp at anything to get better health. And my whole outlook for being in this study has the health part comes first and the weight loss is second. I went off the Trujillo immediately. And in that first week, my blood sugar was dropping 100 points from breakfast to lunch. And she took me, because she'd cut the glipizide in half. And then that first week, she took me off of glipizide completely. So I'd been on glipizide probably almost 10 to 12 years. And in the first week of just the diet, controlled carb, low carb, I was off 2 medications being right there. That was amazing. I was like, what? And I felt fine.
I thought it was important for us to have a medical definition of what diabetes is. I've heard that it's an intolerance to carbohydrates, but I was curious to hear from the medical director of the Joslin Diabetes Center as to how he would define it. Here is Dr. Gabbay.
There are 2 main types, and type 2 is by far the most common. 90% of people have type 2 diabetes. And type 2 develops because of 2 issues. The first issue is becoming resistant to the effects of insulin. And that happens from being overweight, from a sedentary lifestyle, and there's a genetic component to that. So a family history of diabetes makes you more likely to have resistance to insulin. And insulin is a hormone that helps control people's blood sugar. So first problem is becoming resistant to insulin, and about a quarter of the U.S. population is in that state. Most of them make extra insulin to compensate for that resistance, and their blood sugars are normal and they don't have diabetes, but they are at increased risk for heart disease and cardiovascular. What determines who develops diabetes is that first problem of insulin resistance, and then a second problem is the inability to continue to make the extra insulin that's needed. And so they have a problem with their ability to make insulin in addition to being resistant to it, and as a result, their blood sugars rise, and then they're diagnosed with diabetes. And the medicines we use largely work, many of them, either by helping the body make more insulin or be less resistant to insulin.
Dr. Sarah Hallberg is the chair of the Nutrition Coalition Scientific Council. She's also the medical director at Virta Health. And together, they have partnered to conduct the largest and the longest clinical trial looking at treating diabetes with a low carbohydrate diet. And they've had such profound results that if this were a drug trial, we would all be trying to buy stock in it.
My name is Dr. Sarah Hallberg, and I'm a physician and medical director at the Indiana University Health Arnett Medically Supervised Weight Loss Clinic. I'm also the medical director at Virta Health, a remote care specialty clinic aimed at managing and reversing type 2 diabetes utilizing a low carbohydrate diet. I am also Aspen Institute Health Innovator Fellow, and I'm the chairman of the board of directors at the Nutrition Coalition.
Hi, Sarah. I'm so excited to talk to you.
Very nice to meet you.
Very nice to meet you, too. If you want to talk a little bit about how you got into this field and how you sort of looked at this problem in a new way, that would be great.
Absolutely. So I had an interesting introduction into this field. Never in a million years would I have imagined myself here when I first went into medicine. So first of all, medicine was actually a second career for me. My first career was as an exercise physiologist, and I had a master's degree in that and worked for a while in that field before really finding out that you can't beat them, you have to join them, basically, when it came to physicians in medical care, that physicians didn't have a great knowledge base when it came to lifestyle medicine, including exercise physiology, and that I was just not going to get listened to unless I was a physician myself. So it was sort of that situation that caused me to go back to medical school after completing my master's degree and working for a couple of years. And then I had all intentions of going into preventative cardiology, actually, was my goal. But then since I was older, I wound up having a baby my first year in internship. So the first year after medical school. And that moment in the delivery room completely changed my whole goal. And I wound up stopping at internal medicine and practicing primary care just again, so I could spend more time with then what became 3 children. And I was in primary care for close to a decade. And I really realized quickly on that I was just part of the problem, and I was not really playing any role in the solution of what was clearly already, and this has been obviously almost a decade and a half ago, this insurmountable problem of metabolic disease.
To interrupt you for a second, so tell me, how did that happen? Like you're seeing all these patients. I feel like there's so many doctors out there who are in that same situation but haven't had that kind of an epiphany. How would you sort of explain that process?
I think that they probably have had the epiphany, but what has happened is they feel powerless. And that is a really frustrating position to be in. And I felt that way myself. So in other words, we're so pushed, right? You can spend 10 minutes with a patient, and in there, you're supposed to deal with a list of 8 problems, which is the general size of a problem list when you're dealing with multiple metabolic diseases of a patient coming into your office. So, you have to address their cholesterol, their high blood pressure, their diabetes, their obesity, and you're doing all of this in this 10-minute window. So really, what are you stuck with? You're stuck with prescribing more medications because that can be done relatively quickly. And there's no time to address the root cause of these problems, which is, what are you eating? What is your diet like? Tell me what you're consuming. And so again, you become a legal drug dealer. And that's always what I called myself. I'm like, I'm a legal drug dealer. I just write prescriptions. That's all I do. And the system is set up to encourage me to do that at every level. Write a prescription for this, write a prescription for that. And I had what I felt at the time was a really good understanding of lifestyle medicine, given my background. And just there was no opportunity to do this. But then for me, I got a huge break in that Indiana University Health came to me and asked me to start their obesity program. And this was going to be a start from scratch program. There wasn't one in existence at the time. So it really fell to me to say, what are you going to do? How do you solve this, like air quotes, unsolvable problem, which is obesity in this country?
And what year was that?
It's been close to a decade now. And so I had the opportunity because of that to literally get some time within a year period to go back to the books essentially and figure out what we were going to do. I read everything.
What an awesome opportunity to have that luxury too, or you just get to go back to the research. I can imagine that was fun.
And so the thing is that when I was an exercise physiologist, what I was taught is that we should all be following a low-fat diet. That was the nutritious thing. That was the key to health, was removing fat from your diet. And when I had that year, it was really quick getting into the literature, and it struck me, there's like no evidence for this. I've been saying this for a very long time because that's what I was taught. And that's kind of what you take. You take it as it is. This is what you're taught. This is what you learn in medical school. This is what I learned in graduate school. And to be slapped in the face to realize the lack of evidence to support that and understanding how it was failing huge in this country and across the globe as we see unprecedented skyrocketing of obesity and type 2 diabetes among other metabolic diseases, it was a real wow moment.
That's partly because when you're in med school, you don't have time to go back to the raw data sets or the original research. You're just sort of given information and you're quizzed on it. I mean, is that a fair assumption, and why you had the time to go back and look at this research in a different way later in your career?
Yes, but it's even worse than that, because the fact of the matter is, despite the fact that no matter what specialty a physician goes into, they are going to have to deal every day in and out with nutrition-related diseases. And guess how much nutrition is taught in medical school? Next to nothing. And so it's crazy. Physicians come out and they're unprepared. So if they have very limited nutrition, they're told a couple facts, probably nothing that's going to be all that important in translating any of that into their clinical care. And that's all they have to go on. So you're right, no time, but also incredibly limited information that they're given in school. So having that year, I really got mad because I was like, wow, I've been coaching people and guiding people wrong, and there's got to be a better way.
What were some of the things that you looked at that were the most upsetting to you? I mean, I could probably come up with a list that we would agree on, but it would be great to hear from you what you sort of felt made you want to throw your coffee cup across the room.
So it was just that when we started pushing a low-fat diet, when you go back and look at what literature was available there, nothing existed to support that. And the ruckus that was raised at the time, because there were a number of scientists saying, this is not something that we have rigorous evidence for. This is essentially an experiment. And that's really what it turned out to be. So there were a number of trials, like some of the Keys trials that people have cited as being the reason behind it. But when you look at what the quality of evidence was there, it's minimum to none. And so this was a huge shift in what we were feeding an entire population based on scant evidence at best. So when I wanted to open the obesity program, I started it out as a low carbohydrate intervention because there seemed to be some promising research in that area. But what we saw happen so quickly is that our focus really turned away from obesity. Although obesity was improving, people were losing weight, we really hyper-focused on diabetes because we felt like this is the area more than anything where we were having the greatest impact. And it was so rewarding. I just can't even tell you how joyful an experience it is to walk with our wonderful patients through a journey that restores their health. It is fantastic, and it's what gets me up and working every morning.
And since then you linked up with Virta, and you guys have now done some of the only sort of clinical trials looking at the low-carb diet. And just to backtrack for a second, it's important for us to address the statistic, which I think you do a really good job of mentioning, which is that 50% of Americans are either pre-diabetic or diabetic right now, and that it's costing the country more than $3 billion, that's with a B, a year in treatment. And that the idea that this is a disease caused by high blood sugar, and we know that carbohydrates cause blood sugar to rise, and the standard of care is to do insulin injections, which you've basically figured out you can get people off of by putting them on a low carbohydrate diet. Is that all fair?
Yes, the costs associated with this are staggering. It's actually $350 billion, and the rate is rapidly growing. It's actually even 1 in 3 Medicare dollars are spent battling this disease. So what if we could make a difference in this? I mean, what if we could actually make a difference in the disease process? Because once again, going back to standard of care, is that this is a chronic and progressive disease. And I will tell you that I 100% reject that idea. It's chronic and progressive only if you treat it with what has typically been the standard of care. And then it becomes chronic and progressive. I mean, the physiology just doesn't allow for anything else to occur. But when you restrict the cause, you restrict the carbohydrates, the physiology is on the patient's side, actually, and disease reversal can occur, which includes medication reduction. And I was really fortunate to meet Dr. Steve Phinney, one of the founders of Virta Health, at a conference, told him what we were doing in Indiana. And at the time, I was looking for funding for a larger study, and literally over dinner one night, Steve and I had decided to partner on that trial and bringing Virta Health trial to IU Health. And we ran an incredibly successful trial that is actually still ongoing. We're about to start data collection 3.5 years into the trial. So it's actually not the only trial by far looking at low carbohydrate diets in type 2 diabetes, but it is the largest and the longest, and involves some really unique aspects of how do you implement a low carbohydrate diet actually aimed at achieving nutritional ketosis in patients with type 2 diabetes.
Okay, so just to clear up a couple of things, when you say low carb, what do you mean? Like how many grams of carbs, or how are you limiting it?
We see low carbohydrate, that term tossed about all the time. And so people will say low carbohydrate if the carbs are just under 50% of total caloric consumption, which if you talk to any expert in the field, that is not low carbohydrate. So low carbohydrate really is for sure less than about 75 grams of carbohydrates a day. But in the world that I work in, we work more in very low carbohydrate, which is less than 50 total grams of carbohydrates a day. And for patients with metabolic disease, that generally is even lower, less than 30 total grams of carbohydrates a day, because our goal is actually to induce, again, a state of nutritional ketosis. And what that means is it's essentially flipping your metabolism from burning carbohydrates exclusively for energy to actually utilizing fat, which is oxidized into ketones. And these ketones are brilliant fuel sources. And so nutritional ketosis is fantastic. We're, number one, again, taking away the carbohydrates, which are causing glucose and insulin to go up. But number two, when we're inducing the state of nutritional ketosis, we can be sure that fat is the substrate that's being utilized for energy in people. And that, again, contributes to the weight loss. And there are a lot of other exciting benefits that are being elucidated every day in regards to the state of nutritional ketosis, as it's being a powerful anti-inflammatory agent, among others. And so one of the things we always say to patients is pushing the vegetables, make sure you're getting your non-starchy vegetables. And the rule is, though, never eat a veggie without fat. So I always like to tell my patients, imagine that vegetables are a vehicle for fat consumption. People can eat meat, they can eat eggs for sure, but it's actually not required. I mean, the other thing about low carbohydrate is this can be really conform to any style of eating. So people, if they enjoy Mediterranean style of eating, that is so simple to do low carbohydrate. If people want to do a plant-based diet, absolutely can be done low carbohydrate. It's certainly not a strict meat and cheese meal. And in fact, really, that's one of the misunderstandings about it, is that people presume then that it's a high protein, therefore a high meat diet. And actually, it can't be. So a well-formulated low carbohydrate diet aimed at nutritional ketosis cannot be meat heavy. And that is because you would be getting too much protein. Again, a well-formulated ketogenic diet is low carbohydrate, moderate, or we like to say adequate protein. And what's high, it's the fat content that's high.
Can you give me a breakdown of what that looks like? So it sounds like it's like about 30 carbs, net carbs a day, or grams of carbs a day.
Total carbs a day. And that's where we start people, and then we personalize it, which I'll get into in just a minute. But like, what would a typical day look like? So let's start off for breakfast. I mean, breakfast can look like full fat Greek yogurt with maybe some nuts or even some berries, depending on their carbohydrate tolerance. But it's really good just to put like a little bit of peanut butter in a full fat yogurt. That's a quick and easy breakfast enjoyed by many of our patients. You certainly could have eggs or even bacon. We would encourage, something to be added with that additional fat, or possibly even vegetables. So many patients will enjoy like spinach and eggs in the morning is another great way to start the day. And certainly some people enjoy making low carbohydrate muffins ahead of time, and they can have that with some butter on it in the morning. So, breakfast can look like, those are just 3 examples. There are even low carbohydrate pancakes that are just amazing, that are eggs and cream cheese with a little bit of cinnamon. They're just out of this world. So there's just so many varieties just alone for breakfast. And then lunch, our typical patient, I think, which is typical in America in general, is that people will eat salads. And of course, we would say, heavy on the olive oil. And they can utilize some other dressing as well, but we would always encourage additional olive oil to be added to that. Of course, they could still have something like, there's plenty of soups that they could have for lunch, salmon or a small piece of meat. If they would prefer, a lot of times people will have leftovers from the night before, and dinner is the most endless possibility ever. So many different things, from casseroles to, in our house, we utilize the Instapot is all the rage in my household, because we can make stews and roasts and all kinds of things in that very quickly and easily, one-stop shopping. And we always have lots of vegetables. We'll have a salad and a vegetable at dinner in addition to some source of protein. So first thing is we never ever, and this is absolutely true at Virta Health and in the study and in our everyday patients that we treat at Virta, is we never tell someone what to eat. We want to educate them. And so when you get back to this basic physiology, the basic physiology is so easily digestible. We have 3 macronutrients. It's fats, proteins, and carbohydrates. Insulin is our fat storage hormone. Carbohydrates cause glucose and insulin to rise. That is a big problem. Fats don't cause a rise in glucose or insulin. And so if we go back to this concept that we've been taught for so long, that a calorie is a calorie and the calories are all that matters, it defies the hormonal reactions to these macronutrients. And you just can't do that. You can't constantly work against your hormones, essentially, is what we do with a low-fat diet, and expect success. And so we need to have and help people understand that basic physiology. And I always say, humans, we are all different. And that is so important in personalization of any lifestyle recommendation. But there are things that are just human. And again, our reactions to these macronutrients, the fact that carbs cause glucose and insulin to rise in everyone, maybe to different degrees, but in everyone. And fat is that flat macronutrient. That's part of human and nutrition physiology. And so again, getting them to understand that, and you're right, divorcing people from the idea of counting calories is at the exact same time freeing and liberating and terrifying, because we really have to, it's cognitive dissonance, right? That's it. And I like to call it what it is. This is cognitive dissonance. This is fighting against what you've been told all this time. But let's go through these basics. Let's understand why what we've been told doesn't make sense. There's just the basic science behind it doesn't make sense. And people leave and go, oh my gosh. And we get reactions when you really go through the basic physiology, from total anger to actually tears sometimes, when people are like, oh my goodness, I get that. That makes perfect sense. But then what happens is a month, 2 months, 3 months down the line, again, those old habits, the old ideas, you kind of have to remind people. And, going back to the days in primary care when I was a legal drug dealer, now when we're talking about medication management, we're talking about Virta and the experts in de-prescribing, which is just so fun to do, to tell someone, hey, you know what? Today is the day you get to stop your insulin. Even to people who have been like, I can't believe it, I've been on insulin for 20 years. Well, that was 20 years, but tomorrow's a new day and you will start the day without it.
They must have such a positive response to that news. I can't even imagine what that's like.
It's just such an honor to be with people when you get news and you get to celebrate milestones like that. And we get to do it a lot. For example, I'll tell you, in our clinical trial at 1 year, 94% of the patients who started the trial on insulin had their insulin decreased or totally removed. And then people will say, well, wait a minute, that's only a year. Well, guess what the numbers were at 2 years? 93%. So this is not only making those improvements, but sustaining those improvements over the long haul.
And do those people then stay in the study? Like, you're going to continue to follow them for years and years, or is that
Nope,
done?
It's ongoing. So we're just about to do 3.5-year data collection, and it will go out to 5 years. So we're in this for the long haul, and we're interested again in seeing these remarkable results and sustaining these remarkable results. So that is very exciting to be a part of.
And so will you just talk a little bit about what you do when somebody enters the trial, or like for somebody who might be listening who's diabetic? Obviously, I'm not a doctor. I can't give any advice. But in terms of what you guys are doing, you're not just saying like, okay, just, don't take your insulin and just eat a low carb diet. Like, it's very regimented, right?
And it's very education focused. So when someone starts at Virta Health, they meet their health coach, they meet their physician, they actually get a kit of everything that they're going to need: a cell phone enabled scale, ketone monitor, blood sugar monitor, blood pressure cuff if needed, everything they'll need to succeed. And then when they meet their health coach, then they set a date for them to get started. But important to note, set a date, right? So we don't have anyone just jump into this, because there's actually like a pre-planning period. Like, what's in your kitchen? We need to get it stocked with the right things. We have to set people up for success. So stage 1, if you will, is let's prepare your environment. What do we need to have? What do we need to make sure we don't have? What kind of discussions do you want to have with family? Who are you going to involve in this? Who is your support people? Who are going to be your accountability partners? Of course, we're providing accountability partners, especially through the health coaches, but who are the accountability partners in the home or in the workplace? So those kinds of pre-planning things, and then getting started after the education pieces have been in place with learning how to limit carbs. And again, the health coach will be, how did you do today? What did you have for breakfast? And they're making these recommendations personalized because they're reacting to biomarkers that the patient is entering. In other words, if their blood sugar dropped significantly, hey, what happened last night for dinner? Because it went really well. Your blood sugar dropped this morning. If it didn't drop and we expected it to, let's go back and look again at what dinner was. So we're able to make recommendations almost in real time. So it's not like you go into your doctor's office in a month and you've lost 2 pounds. Well, what worked and what didn't during that month period? Because we're attaching it right away.
And do you find that the sort of the range of nutritional ketosis through those blood glucose monitors, is there like a sweet spot that you guys really like that people could look for if they were testing their fingers at home?
As a general rule, we look for 0.5 millimoles beta hydroxybutyrate via a finger stick. And that is actually based out of the work from Dr. Steve Finney and Dr. Jeff Volek, where we seem to see most of the advantages of nutritional ketosis take place. But there is clearly some person-to-person variability. In other words, there are people who are just hitting a home run in inflammation markers, diabetes reversal, and they tend to be around 0.3. And there are certainly people who are finding great deals of success who are higher than that. So again, that's one of the advantages of having a health coach and physician, because we can help watch a person's individual response and make carbohydrate and ketone goals accordingly.
And so one of the other things that I feel like I have to ask, because another pushback that I often hear on the sort of low carb lifestyle, or that sounds strange, but is the idea of kidney failure, right? Or like kidney damage, which it seems like people are really hung up on that idea that you can destroy your kidneys on a low carb diet. Is there any evidence to support that idea?
No. So here's where that came from. Like, why is that even a thing? Like, why did anybody think of that? And really that dates back to when low carbohydrate was perceived as a really high protein diet. And protein and kidney function is a really hotly debated area in nephrology or kidney specialty. How much protein do patients with chronic kidney disease, how much should they be consuming? I'll leave that to them to debate. The thing is that a well-formulated ketogenic diet is never high protein. And so it's kind of a moot point. And again, if you look at the studies and the data on this, we don't see a negative impact on kidney function. So there's no evidence to support that notion at all.
Now, you just recently went before Congress and presented the results from your study, and I assume some of this sort of educational piece. I can only imagine what that was like in terms of going before the people who are recommending the standard American diet or even supporting the American Diabetes Association recommendations. How did that all go? What was that experience like for you?
It was great, actually. And I think, interestingly, members of Congress are interested. They realize that we're in big trouble and they're interested in changing. I think that there has been some paralysis in doing that, which I hope we will be able to overcome. There certainly is, though, interest. And on standard of care and the American Diabetes Association, I want to share some really exciting news. And that is that in the 2019 standards of care in diabetes, which comes out every year, it's essentially the American Diabetes Association guidelines. For the very first time, they acknowledged low carbohydrate diets as a recommended eating pattern. So for the very first time, they are a recommended eating pattern. And they went further to say that low carbohydrate diets are the eating pattern that shows evidence for disease reversal. Although they did not call it disease reversal, they acknowledged the ability to decrease medication, which is, of course, reversing the disease process.
My immediate inverse question is going to be, what about prevention? I mean, when we're talking about kids, I'm in the process of trying to get the sugar out of my kids' cafeteria. And one of the things that I've gotten pushback on is that the parents get really upset when the chocolate milk is taken away or when the desserts on Friday are taken away. And I find that to be so interesting. And some of the parents that I've talked to candidly about it will say things like, oh, well, Johnny's so skinny, I can't get him to eat anything. And so I have to give him this crap because it's the only thing he'll eat. And I wish that somebody could, and I'm hoping that you can, sort of articulate how this is a cumulative problem. People don't start out with this, that it develops because your body becomes metabolically incapable of processing the sugar. Is that correct?
Yeah, I mean, it floors me. It just floors me that parents are not universally embracing this. I think we have a lot of parents who are getting it more and more. But I mean, if I could tell you how many patients in my clinic, the same story. I was a thin kid. I never had to worry about this before. This is new to me. Just because you have a thin child doesn't mean you can let down and let them eat sugar all the time. And that's exactly what we do, because they're getting sugar in all these different ways. Every reward, every treat, it's just sugar and sugar and sugar. And we send them off to school with cereal, which is, again, just sugar. And we say, oh, it's great because this is whole grain cereal. really you're just giving them a huge carb load in the morning, and then you're putting your low-fat milk in it, which is just more sugar, and it's more and more and more. And so what I tell parents is, oh my goodness, this is so important to start as a family. Now, low carbohydrate for kids can be very different than it is for an adult with metabolic disease. I mean, I consider my children to be low carbohydrate kids. That doesn't mean they never have sugar. It means it's not something that's in our house. And I have to deal with it. They're going to get it when they leave our house at times, and I can accept that. But in our house, they get protein and vegetables, and they start off their day. I mean, my kids like eggs, and they start off their day with eggs, and I make sure they have plenty of fat and protein in the morning. And I always tell parents, say, if there's one thing that I could do, because I get that question a lot, and that is a really easy to answer question. If there's one thing you could do, never give your kids juice or soda. Not sometimes, not because it's a vacation, not because you're taking them out to a special dinner. Juice and soda are nevers for all children. There's no reason that there is nothing beneficial about those with kids. And so if parents could just take that one single step to never let their kids have juice and soda, I mean, that would be a huge first step.
I'm in complete agreement. I feel like we tell our kids when they go to birthday parties that they can have cake or juice. That's sort of the choice they get to make when they're at a birthday party. But I think people think we're terrible, like we're so mean for doing that.
Oh, juice is for you, right? People think. And actually, if you look at it, it's worse than soda. It's like a sugar bolus. It's like an iced sugar bolus.
That was Dr. Sarah Hallberg, who I feel like opened all of our eyes to this idea that if you're diagnosed with a chronic disease, it does not mean that you're going to die of the chronic disease. There are certainly things you can do about it. And in her clinical trial, where they've reversed 60% of diabetes in the people who were in the trial, I think is going to be a landmark study we're all going to look back on. Some of the big takeaways for me were the fact that the cholesterol in these people who participated in the study were not negatively impacted, that kidney function is not negatively impacted by a low-carb diet, that giving kids sugar for breakfast is setting them up for failure, probably in terms of academic success as well as in terms of their overall health, and that this is a cumulative problem. So even if your kid is skinny and has lots of energy and doesn't like to eat food, giving them the wrong food is going to make them sicker sooner. And obviously that's not something that any of us wants. When Dr. Hallberg said that the American Diabetes Association had changed their guidelines to include a low-carb option for diabetics, it was the first I had heard of it. I was pretty shocked because I feel like that would mean that the Virta study has already had a massive impact on the sort of established way of treating diabetics. I was curious what Dr. Gabbay would say about this addition in the ADA guidelines, and sure enough, he has a slightly different take on it. Here he is.
The American Diabetes has already sort of come out this year with a more flexible approach to diet. That includes potentially lower carbohydrate, but not low carbohydrate can mean a lot of different things. The version that Virta sort of advocates is extremely low carbohydrate and ketosis, and there are some concerns about the safety of that for all people with diabetes.
So
that's not what the ADA has come out behind.
Okay. And so from your research and your experience, when you have you had a chance to look at any of that?
Sure. Oh yeah, absolutely. Yeah.
And so what do you think? What do you make of that?
I think there are some patients that can benefit from that. Absolutely. I might make some more general comments about diet. When most diets are compared to each other, for example, for many years, the advocacy was really around low fat. And then over the last several years, it's moved to lower carbohydrate. When you do studies that compare one to the other, they're pretty much equivalent. It's difficult to show a big difference. And the reality is in each group, there are people that do extremely well and then other people that don't do well at all. And so what I take from that is that it sort of depends on the person. For some people, their best strategy for losing weight is going to be cutting carbohydrates. For some people, it's going to be cutting fat. the ideal is people meet with a nutrition specialist that helps to guide them on that. But I'll often ask patients, have you ever tried to lose weight? Have you ever been successful? And what worked for you? And people often know what worked. And that probably is the best predictor.
You see, I feel like one of the things that and I'm sure you know this, but like they say that they had 60% of their subjects reversed diabetes and 94% of their subjects were off insulin altogether or reduced their intake of insulin. So that doesn't seem like some people, right? I mean, that's the majority of the subjects in their study.
Yeah, there may be some caveats with that. It's not necessarily all comers. It may be a somewhat selected group. It requires a pretty significant ability to adhere to something that not everybody's willing to do. And so, another way to frame that is there are a variety of different intensive programs to lose weight. And people that follow those programs can do extremely well. The question is, what percentage of people are those?
Dr. Gabbay's point that there's a connection between obesity and diabetes and that's probably the biggest risk factor, and essentially getting the weight off any way you can is beneficial, is definitely how people have traditionally thought of this. But there is another school of thought that thinks of this as a hormone dysregulation within the body. And there's some research out by Natal and Ganan, and we're going to link to it on our site. They have a series of well-designed controlled experiments where they're demonstrating that carb restriction is effective in treating diabetes under conditions where no one lost weight. That's really significant, right? Because that basically means they are regulating the hormones by removing the spikes in insulin, even though the subjects aren't losing weight. So I think there's sort of two schools of thought on this. The way that Dr. Hallberg talks about it, she's basically saying, hey, if you get rid of the carbs and you don't have these spikes, then the body's sort of not in shock and it can manage better. Whereas when you're eating a low calorie diet, you could be eating a low calorie diet of, say, Peeps, and that's all sugar, right? So you're just constantly spiking your system. That could make you diabetic or pre-diabetic. So I think that's really interesting. Okay. To wrap up, we're going to also hear from Dr. Gabbay about the idea that Jocelyn has been treating people with diabetes on a modified low-carb diet for a long time.
We've been doing that for a number of years, not to the extremes of developing ketosis as their work has been, but absolutely, we've been early adopters in rolling back some of the historic recommendations of the American Diabetes Association, and in part some of our studies that have shown long-term weight loss through a program we have here has helped to sort of identify, there's a rationale for lowering carbohydrates and not being at sort of 60%, which at one time was the sort of standard recommendation.
Dr. Gabbay made some good points. I think it's important to mention that this was not a randomized, doubly blind sort of controlled trial, meaning that people weren't just randomly picked and then tested in a way where they didn't know which diet they were on, or that you took one group and fed them one thing and the other group the other, and then you could compare. However, I think given the fact that they got the results that they did with 60% of participants reversing their diabetes and 94% of participants eliminating or reducing their insulin, this is still incredibly significant. And so you can be hard on the rigor of the study, but I actually don't think that that takes away from it too much, but it's an important point. I also thought it was really interesting that he sort of seemed to say the most important sort of risk factor for diabetes, for probably developing it and for treating it, is being overweight. And that if you lose weight on a calorie restricted diet, that's great. If you lose weight by eating ad libitum and you're on a low carb ketogenic diet, that's fine too. That the point for him seems to be really, you got to get the weight off. And then the sort of more nuanced takeaway for me was when he said that Jocelyn was an early adopter of the low carb recommendation, because I don't know that he would have said that 5 years ago. I wonder whether the Virta trial is now opening people to this idea that low carb is a way of treating diabetes and making it more of a thing the conventional sort of established medical systems are saying, oh yeah, we've been doing that too, because now the door has sort of swung open. So I don't want to leave you all without going back to Kim and hearing how she's doing. So here's Kim. So will you just give me a rundown of what medicines you were on before that you are no longer on?
I was on Trujeo, 38 milliliters. I was on 10 milligrams of glipizide. I was on 2,000 milligrams a day of metformin. I was on 3 blood pressure medicines. And I don't even know that I could name all 3 of those. So we'll just say 3 blood pressure medicines. I was on 80 milligrams of omeprazole for GERD. I was on an iron pill. I no longer have to take that. The only things I'm on at this point is I still take a blood pressure pill, and I'm going back to Dr. Hallberg for my 3.5-year checkup, and we might discuss that. So I'm hoping to be able to dump that, but if I can't, that's okay. And I take Tylenol for arthritis. I was on arthritis medicine as well, a prescription arthritis med. And
that's fantastic.
And I may be missing something. I didn't count how many of those were, but I know it was 10. So technically, I'm only on 1 prescription med at this point, and that's for blood pressure.
And how are your numbers? How have they changed?
Well, I've gone from 268 fasting to this morning, I was at 105.
So if you could go back in time and tell yourself what you now know, what would that experience be like?
I would have eaten butter. How's that?
There's something so profoundly upsetting and just as exciting about Dr. Hallberg's research and the fact that everything that we've been taught basically about what we eat might be wrong and that it's actually making us sick, but that those sicknesses aren't things that we have to live with, that we can reverse them by simply correcting what we're eating more fat, eating less sugar, and that we can do this as a family and improve the future generation's ability to live longer, healthier lives. I'm Emily Kumler, and that was Empowered Health. Thanks for joining us. Don't forget to check out our website at empoweredhealthshow.com for all the show notes, links to everything that was mentioned in the episode, as well as a chance to sign up for our newsletter and get some extra fun tidbits. See you next week. Hi, it's Emily, your host of Empowered Health. I'm back with a bonus episode, sort of following up on our diabetes episode. So if you haven't listened to that one yet, definitely check it out, because basically what happened was we recorded that one, produced it, we're done. I went to bed and then was like, no, I still don't understand. I can't say that we've conclusively covered this properly, because it seemed to me like there were really different opinions on what is diabetes. If it's really an intolerance to carbohydrates, which it seemed like both experts agreed on, then why isn't the treatment eliminating carbohydrates? That just seems so simple. So I went back to Dr. Gabbay. I emailed him basically in the middle of the night and was like, I still have questions for you. Can we please talk? And I wanted to get a better understanding from him. He really, in the interview, made me feel like this is a weight management problem. That if you lose the weight, then you're treating the problem. Or if you don't gain the weight, then you're treating the problem. But the thing is that the guy who started Virta Health, who we didn't really have a chance to talk much about in the episode, I talk a little bit about him in the column. He is a world famous triathlete who basically realized that he was pre-diabetic because of the high carb diet that he was on. And so I sort of thought, there's like this joke about skinny fat people, that people who are getting sick and metabolic disease, even though they're not overweight. And there was the study that I mentioned at the end of the episode that basically looked at treating diabetes on a low carb diet with people who didn't lose weight. So if people aren't losing weight and they're still having this benefit simply because when you eat the sugar, it's spiking your insulin. And when your body can't produce the insulin, that's when you have diabetes. It felt to me like giving a kid with a peanut allergy just an EpiPen and telling them that they can eat all of the peanut products. Like, that's how we're treating diabetes. That doesn't seem right. And I can't imagine a medical professional would say that that was right. So I had to go back to Dr. Gabbay, and in some ways he was able to sort of explain the perspective that he has, and in the treatment of it, how they don't actually think that sugar causes diabetes, and that they think you can be on a low-fat, carb-rich diet and have better results for your diabetes. But the big takeaway seems to be that there is this idea of management of glucose. and management of insulin with drugs. And so if you were to sit down in a doctor's office and they were to say to you, look, there's this diet, it's really hard to follow. A lot of people fall off of it, but if you can stick on it, you might not need your medications anymore, or you certainly wouldn't need so many of them. If you can't live without your cookies and your brownies, then okay, go ahead and do that, but we're going to have to give you lots of medicine and you're going to get sicker and sicker over the years, and this is going to be an ongoing management. I feel like most people would say like, okay, let me try the diet. I didn't know that was a choice. And Dr. Gabbay definitely makes the point that like they are not saying low carb isn't an option. It just seems like they think it's too hard for people. And that's where this podcast really comes in, because I feel like if you had the information, maybe you'd stick to the diet, right? Or maybe you'd at least be able to make that autonomous decision on your own, rather than somebody just telling you like, oh, just take all these drugs and just keep taking them. So we're going to get into it a little bit more here. This is a short episode, but I just felt like in my soul, I needed to follow up.
So I know your time is super important and I don't want to take up too much of it. I think what happened when I was writing up my column and we were going through the podcast is I realized that there just seems to be this big disconnect, and I feel it. And so I sort of felt like I needed to come back to you and just...
Sure.
So I think one of the big takeaways from what you explained to me is that there is a direct connection between obesity and diabetes, and that if people can get the weight off, whether it's low carb or whether it's low fat, kind of the best thing you can do is to do that, probably from a preventative stance as well as a treatment stance. But what I'm struggling with is that it seems like most of the sort of understanding of the disease is that it's a dysregulation of hormones, right? So like the more glucose you sort of need to balance out with insulin, the more your body kind of runs out of the insulin, and then you need it from an outside source. But if fat is a stabilizer, right? So like your body doesn't spike on when you're eating fat, even though that could be a harder diet to adhere to. Why isn't that the standard recommendation?
I guess because there really isn't clear evidence that that is any more effective than a lower fat diet.
In terms of losing weight?
Yeah, because whenever you do head-to-head studies, they're pretty much equivalent. And I think the issue is that certain people in both groups do better with one or the other. But if you take all comers together, they're relatively equivalent.
But what's hard for me to understand is like that's focusing just on the weight, when it seems like the underlying problem is really this hormone dysregulation, which comes from eating things that spike your glucose.
Yeah, not exactly. So let's say, there used to be this thinking that people developed diabetes because they ate too many sweets as they were growing up. And there's no evidence to say that's true. If you gain weight, absolutely you have an increased risk of diabetes. But eating sugar or not eating sugar is not the cause of diabetes.
Is that true? I thought that was like, so now I'm completely baffled, because that was my understanding, was that the more you spike your insulin, the less insulin you're able to produce.
Yeah, no. So when you have diabetes and you need to spike your insulin and you can't, it uncovers that problem more obviously. But it's not like you have a finite amount of insulin, and if you have overtaxed the system for too long, you develop diabetes. That's not the case. And so that's a popular way of thinking that, my pancreas just tires out because I've been eating all this sweet stuff or all of these spikes. No, it's more when you have diabetes and you can't make enough insulin, yes, then you uncover that problem by putting your body in a situation that needs to make extra insulin.
So you don't really need to produce extra insulin if you're eating low-carb, fatty kind of diet, right?
Yeah. Right. So if there's sort of two, maybe it's easier to separate. There are people that don't have diabetes and people that do have diabetes. If you don't have diabetes, whether you eat sweet things or not, your body makes the right amount of insulin and everything's all good. And that's a wonderful way to go through life. But a subset of people have a problem where they can't make enough insulin. And if you put yourself in a situation where you have to make a lot, i.e. eating a lot of carbohydrates, that will uncover that problem. But you have the disease. You had to have had the disease for that problem to exist. 75% of people that don't have any abnormalities in insulin production go along just fine eating whatever they eat, and the body works well.
But if we're talking about, say, like we had said before, half of the country is pre-diabetic or diabetic. So for those, let's talk about those people.
Right. So those people, when they eat more carbohydrates, their blood sugars may rise. They're not going to develop diabetes any quicker because they overwork their pancreas. There's, the idea of it being a tired pancreas has, it's not clear that that's true.
Okay. But so once you have the disease, when you eat sweets, you are spiking your need for insulin.
Right.
Correct?
Unless you manage it with medication or insulin or, something like that. Right.
So, but if the standard course of treatment is to manage, as, you've sort of explained to me that basically that, as you need more insulin, your body can't make the insulin, so you need an exogenous or an outside source of insulin. And this is sort of now I feel like we're going back to the original question, which I'm still not clear on. So forgive me, because I feel like this is probably really simple for you, but I think for a lot of people it's probably not.
I think it is a little bit confusing. I think part of it is that this is all a little less clear.
Okay. So, but the thing is that we do know that when you eat fat, you do not need outside insulin, right?
No,
you don't have any
still
insulin
need
requirement.
insulin. Yeah, any time you eat, you need insulin, for the most part.
But for somebody who has a, depleted supply or their pancreas cannot produce enough insulin, if they're going to need more when they eat sweets than they would
Correct.
when they eat fat.
Correct.
Okay.
Correct.
So that's true.
Right.
Okay.
But the need for insulin is a normal part of metabolism.
Okay. But so then why, it sort of feels a little bit to me like if somebody is, if we know that cigarettes cause 90% of lung cancer, then saying to somebody okay, well, if you don't smoke the cigarettes, you're not going to be as likely to, develop lung cancer.
Right.
Or a peanut allergy is another.
This is a little different. First, eating the sweets didn't give you diabetes. And once you have diabetes, well, let's put it this way. Maybe there's another way to get at it. It's all about maintaining good blood sugar control when you have diabetes. And there are different ways to do that. One is to cut back your carbohydrates, and your blood sugars may be better just because of that. Or you could eat carbohydrates but maintain a normal weight or lose weight and may need appropriate medication. If you lost weight, you're probably getting a lot of the benefit right there, even if you're eating carbohydrates.
But so this sort of feels to me like a kid with a peanut allergy, where we could say, okay, go ahead, Jimmy, have your PB&J, but we're going to give you an EpiPen every time you do. Or you could just not eat the PB&J.
That might be true if being on a low-fat diet didn't result in weight loss.
But if we know that it's the carbohydrates that are causing the spike in insulin, that's the part that I sort of feel like, why wouldn't that be the suggested?
There's nothing wrong with a spike in insulin, right? That's the way the body normally works. It's
but if the body
problem
can't
because
produce
you can't make enough.
Yeah, right. But if you don't need it, if there's a diet where you don't need to make a lot and you don't need to be on the medication.
That's one way to skin the cat. That's one way to skin the cat.
But so why don't you think that that's the, I understood what you were saying to me before about, this is great, has a lot of potential, but how many people will actually adhere to it? Is this something that is really realistic? But I guess from my sort of patient perspective, it feels, and I should say I don't have diabetes, but if I did, I feel like if I
you might try that tact.
Well, if somebody,
there's nothing wrong with that
gives
tact.
All the information to say basically, look, you have two choices. You can continue to eat carbs and sweets, and if that's really important to you, then we have medicine we can give you for that. Or if you prefer to not be on medication, we can try this route. I feel like wouldn't a lot of people...
but you'll still need medication because you still have a defect in your production of insulin, and you're still insulin resistant, and you're still at risk for heart disease. So the disease doesn't disappear. You still have the disease. You're maybe not manifesting it with high blood sugars as much, potentially.
Well, but that's what's so interesting about this Virta trial is that it seems like they reverse diabetes in 60% of their subjects. So they don't need the medicine.
In a self-selected group of individuals, yeah.
Okay.
And I think that's great for those individuals.
And so, okay. I mean, but I guess it just sort of feels like
let me throw another curveball. That's helpful. So if I took a group of people and I had them lose a dramatic amount of weight, they also would they would look just like these people that Berta has converted, so to speak. So you could do that with a very low-calorie diet. There are a variety of different ways, and you could do it with bariatric surgery.
But
all of those ways you lose, if you lose a lot of weight, your diabetes gets dramatically better. And if you're earlier in the course of the disease, it in essence looks like it's reversing. You don't need any treatment. You could do that through extreme weight loss from a variety of different ways. Verta is one of those.
That confuses me again, because it makes me feel like if this is about not being able to produce enough insulin.
But by losing weight, you dramatically improve the amount of insulin you need, number one, and probably also improve some of the inability to make enough insulin.
Okay, so your body is able to sort of recover, in a sense, when it loses the weight. Is that correct? I mean, are people who lose that much weight going off of insulin?
Sure. And any which way you do that works. Any which way you lose a significant amount of weight. Bariatric surgery is another example. People lose a lot of weight. Many of them get off insulin and get off all sort of medication. People that are on a low-calorie diet where they're given sort of liquid replacement lose a lot of weight. Also, similarly, don't need medication many times or insulin. I'll add one other thing. And if you take somebody who has been on insulin for a number of years, in other words, that has had diabetes for a relatively long period of time, and you do any of the things that I described, including, I suspect, the Verta diet, they won't get off insulin because their defect has gotten to the point where they make too little insulin to get by. So if you wanted to prove that your treatment was effective at reversing diabetes, you would choose people that were early in the course of the disease, that have milder disease, and they're the ones that will respond the most. And conversely, if you pick people at the other side of the spectrum, the results wouldn't be as robust. It'd still be helpful for them to lose weight for a variety of reasons, but may not have as dramatic a result.
Well, and so that makes me think that it's a cumulative, that the longer your body is not able to produce insulin, the more damage is done. Or the longer... Or you make less and less insulin over time. You have an inherent disease that is leading to the loss of the ability to make insulin, and that continues to get worse and worse, and that's progressive. Okay. There was a study that I came across that was by Natal and Ganan, I don't know if you're familiar with this, but they were able to get patients to improve their diabetes where there was no weight loss using a low-carb diet. And I thought that was particularly interesting because of, the idea that you're basically saying this is a weight disease, there's a direct connection between the sort of obesity epidemic and the rise in diabetes.
Yeah.
But
I'm not familiar with that study.
Okay.
So yeah, it's hard for me to sort of guess what's going on there.
Okay. I mean, I just sort of feel like it seems to me like there's so much to this.
And don't misinterpret that I'm thinking that being on a low carb diet is a bad thing. And no, absolutely, it's one of the effective treatments.
And so, I mean, I feel like if it were you and you went into the doctor and they said, you're diabetic and we sort of have these two options for you. I feel like at least there should be two options presented. And I think you guys
to being on a low carb diet, absolutely. We certainly do suggest to people to cut back on carbohydrates and or cut back on fat. But I'd say we lean more towards cutting back on carbohydrates to some degree, not to the extent of the sort of Verta type of thing where you're highly ketotic, because that may have some downsides that there's some concern about. But certainly cutting down on carbohydrates makes sense.
And then,
but
just to go
really
back to
for the purpose of helping people lose weight.
And so with the idea that sugar doesn't cause diabetes, I mean, I feel like we know that there's this connection between like sugar and all these kids that are developing fatty liver. And, you know, I feel like it's so interesting to me, this idea that like people are so protective of the sugar in their diet. Like,
oh, no. I'm not saying sugar is a good thing, you know.
But you don't think
saying,
that there's a link between sugar, like our sort of overall American increase in sugar and the development of obesity and diabetes?
Yeah, right. So that's, I guess, where I put it is it's the sugar that leads to obesity, which then leads to diabetes.
Okay, and you can tease those things apart. I mean, I don't think that they're necessarily mutually exclusive, right? Like sugar may lead, somebody like the guy who started Virta, he was this like world champion triathlete, whatever, realized that he was pre-diabetic. And, you know, he attributes that to the amount of sugar and carbs he was eating in his diet, even though he was like a super fit person.
Mm-hmm.
And that's obviously anecdotal, one person, right? I'm not trying to make any,
exactly.
But there's this whole idea of like skinny, fat people.
I'm just going to play devil's argument and
Sure.
devil's advocate. So there are many people that have lost a significant amount of weight on a low-fat diet and have seen a lot of health benefits from it and lowered their risk of obesity and cardiovascular disease and diabetes. So there are many people that are successful at a low-fat diet. It's been around for years, and it works too. It's really all a matter of what you stick to. And so, you know, it's not like people weren't successful for the last, you know, decade or two where low-fat was the, you know, the Dean Ornish diet. Wow.
Well, but I feel like people have gotten thicker, right? I mean, like, I wouldn't say as a population that diet has worked.
I think people have gotten thicker because they're not following these things. And what they substitute the low-fat diet, the quality of the carbohydrates to.
Yeah, I mean, I feel like if you were on a low-fat diet that was like natural whole foods, like you just ate a lot of fish and vegetables or something, right? But that's not what most people are doing.
Right, but if you did that, that is, you know, likely as beneficial as a low-carbohydrate diet. I guess that's the main point.
Right, you're not pushing like
one or the other.
Yeah, you're not telling everybody to like go eat Twinkies and be fine. You're saying
not at all.
Yes.
Okay.
Yeah.
Right.
Okay.
I was glad that I got to talk to Dr. Gabbay again. I feel like there's still some disconnect for me, and I wanted to follow up with Dr. Hallberg again. I'm starting to feel a little bit like some sort of like high school debate coach person who's like trying to get both sides of this. But it's a little bit incredible to me that we don't have a clear definition of what's causing diabetes, let alone sort of a universal understanding of how to treat it. I definitely feel like if people were given a choice between taking lots of medication or changing their diet, they would change their diet, right? So why isn't that the norm? I'm still a little confused about that. And I feel like Dr. Gabbay's point that sugar doesn't cause diabetes and that really getting the weight off is the most important thing for somebody who's diabetic in order to see some sort of tangible benefits from that was something that I absolutely had to bring back to Dr. Hallberg and see, did she agree with that? Had I sort of misunderstood this before, or is there something else to consider? Here is Dr. Hallberg again.
First of all, let me start by saying thank you for carving out a little bit of time last minute. I feel like when I talked to Dr. Gabbay, I was hoping to get sort of a conventional treatment perspective from him. And the first time that we talked, which is the episode that's actually live right now, my big takeaway was he was basically saying, like, that's great that they're having success with low carb at Virta, that this is, you know, really a disease that comes about because of people being overweight, and that no matter how you get the weight off, you're better off for it. And I sort of, you know, took that answer. I pushed back a little bit, but I thought, okay, well, you know, he's making a point, and maybe it's easier to lose weight on a low-carb diet. Maybe some people are resistant to that, but this is about weight. And then I literally went to bed, and I was like, no, like this is about an underlying dysregulation of a hormone. So how does that make sense? Like if I was on a low-fat diet and I just ate Peeps, right, or like just sugar, why would that work in this case? And so I called him back, and I had a conversation with him this morning, and I basically just explained that. And I said, you know, I think there's all this sort of confusion about this, and I'm struggling with the idea that, like, if you could go on a low-carb diet and get off your meds, why isn't that the standard diet that's recommended. And he basically corrected, or he said that I was inaccurate when I said that like diabetes, too much sugar was causing diabetes. So he really thinks it's about weight. And I sort of said, you think you can really sort of tease those things apart because, and then I mentioned how, Sammy was this world famous triathlete and there's all these sort of fat, skinny people that we have walking around, right?
Right.
And that it doesn't seem like they're really, there's a prevention. If you're skinny, you could still be getting sick from this stuff. And one of the things that and then I tried to sort of give the analogy of like, if we know that it's an intolerance to carbohydrates, how can we possibly tell people to be eating carbohydrates? And he was sort of saying, he kind of kept going back to this idea that it was a weight model. So I just wanted to give you a chance quickly. We don't have, and I don't want to turn into something where it's like, we're on the debate team and I'm going back and forth.
Right.
But I felt like, what, this is really important because if we don't understand the underlying cause, then how can anybody treat it?
Yep. So, I'm happy to comment on that. So I think the question, is low carbohydrate nutrition intervention successful because of the carbohydrate restriction or the weight loss? And I think that we can confidently say that weight loss is a contributing factor to the development of normal glycemia and the ability to get off of medications. However, when we look at other interventions where weight loss occurs, we don't see the same profound results. And although the vast majority of people with type 2 diabetes are overweight, we know that that's not everyone. There are plenty of people who are still normal weight who develop type 2 diabetes. And there are several studies that definitely indicate that there's more than just weight loss contributing to the blood sugar control with a low carbohydrate diet. And it's very similar actually to bariatric surgery in the quick resolution of hyperglycemia or high blood sugars. When people go into the hospital and they have bariatric surgery, they usually wind up leaving the hospital off of their diabetes medications. So this is just in a day or two. And they haven't lost any profound amount of weight at that point. And that is exactly what we see with a low carbohydrate nutrition.
So what are you attributing that to? That they haven't eaten and they're in ketosis that quickly, or like how would you explain that?
Well, they're restricted on carbohydrates for those first couple of days, right? And that is exactly what we see without the surgery when we restrict carbohydrates just with a dietary approach. It is within a day, 2 days, that we can see these profound improvements in their blood sugar, and they haven't lost any weight yet. And so, it happens very quickly. And I think this question of being able to tease out exactly how much of it is weight and weight loss, like I said, we know that that's contributing, but how much of it is the carbohydrate restriction itself? And that is a profound part. And I'm pretty excited because we have 2 studies. Verta Health is not involved in them, but there are 2 people who are going to be publishing studies looking at this very question. One relatively soon and, one hopefully within the next year.
What is that? It's like treating people on a low-carb diet or a ketogenic diet.
While keeping their weight stable.
Okay. I was able to find a study that, and now it's like Ganan is one of the authors, and there was another one where it seems like they did have good results treating diabetes without weight loss on a low-carb diet.
Yes. So Ganon's study definitely is one of those that really indicates there's more to it. And there's another study by Jeannie Tay where when you look at her 1-year results, what we see is that we see the equal amount of weight loss in those who had blood sugars uncontrolled at the start of the trial. So they lost the same amount of weight, yet the low carbohydrate diet group had greater improvements in A1C. So again, there are a number of trials already out there, but to have a trial that is very specifically looking just at this subject, can we keep weight stable and see improvements in glycemia much more with carbohydrate restriction versus any other dietary approach. And like I said, there's at least a couple that I'm aware of that are going to be, that have either been completed or are ongoing looking at this very subject. And I think that what we're going to see is what we all see in the clinic, which is you don't have to lose a profound amount of weight to have carbohydrate restriction work. In fact, it can actually be one of the frustrating things for some people. I mean, not everybody loses, a huge amount of weight when they go on a low carbohydrate diet. Many people do. But what we find is even in those people who don't, they can still develop normal glycemia and get off their medications. In other words, they can still reverse their diabetes. That really argues against this being only weight loss.
Well, yeah, and that like a low fat, it was interesting because I wanted to make sure that I think this idea that like anybody's a fan of sugar, it seems crazy at this stage of the game. And so I said to him, you're not promoting Twinkies, right? And he was like, no. And I was like, so like you're basically saying like you could go on a low fat diet of like fish and vegetables and you could get these results too. Is that what you mean by a low fat diet? And he was like, yes, exactly. And I sort of was like, well, that's not what most people are eating when they're on a low fat diet, right? Like they're not eating the super sort of like paleo low fat version. They're eating like very processed high sugar low fat diet, I think, right?
Well, even if they're eating whole food though, low fat diet, I mean, where are the studies? I mean, there's been so many studies on low fat diets. I mean, where are the studies on diabetes reversal? We just don't have that, right? When we look at diabetes reversal, we have 3 ways of clinically proven ways to reverse type 2 diabetes. And that is number 1, a bariatric surgery. Number 2 is a very low calorie diet. And the thing is, when you get calories low enough, you have by default a low carbohydrate diet anyway.
Because everything's low.
Right. And then number 3 is low carbohydrate diet. And so, the thing is, we're not seeing a low fat diet on there. I mean, unless, again, the low fat diet is incredibly calorie restricted. So it just really, again, argues against the idea that this is, not the carbohydrates. I mean, why are we not seeing, again, reversal with other eating patterns if it is not the carbohydrates? And we just don't see it.
And so then the other thing I wanted to make sure I gave you a chance to answer to was that he makes an implication that if he definitely picked on the fact that this was not a randomized study, right? Mm-hmm. And in thinking about that, I think, for the purposes of the podcast and what I hope to do in terms of getting really good information to people, I do think it's important to point out, how studies are different. I think in your case, though, it's like you're working with people who have diabetes. You're not going to take the people who don't have diabetes, right? So it's sort of like an interesting idea in terms of the design of the experiment. But I also sort of, in this follow-up conversation with him, he makes an implication that if he were going to reverse diabetes in subjects, that he would try and find people who were newly diagnosed with it because it's easier to reverse. Whereas somebody who's had it for 20 years, you're never going to reverse it. And I realized, when we talked to Kim, the subject that we interviewed for the podcast, my understanding was she had diabetes for quite some time, but I thought it would be worth asking you, like, in the sample population that you have studied, were there people who had diabetes for a long time, or were they all very newly diagnosed?
I am so glad you asked that question. This is a really important fact about our study. And that is that if you look at other studies on diabetes, what you see is that they have intentionally chosen newly diagnosed people. And in most cases, they exclude people who are on insulin. Our study took all comers. So we have people in our study 15, 20 plus year history of diabetes. And so we chose people who were on insulin. I mean, we wanted to take those people. So if you look at our patient population compared to other nutrition interventions with diabetes, our patient population is just a lot sicker. They are much higher risk of not reversing their type 2 diabetes, which makes our clinical trial results even more remarkable. And I'll tell you about an important comparison. So an important comparison that's done about the same time frame, they just released their 2-year results, and we are about to release ours, is a trial from the UK called the DIRECT trial. Now, this was a very low-calorie diet approach. So the patients were on just over 800 calories a day for 3 to 5 months and then switched to a low-calorie diet versus ours where there was no calorie restriction, but they were coached to consume restricted carbohydrates only. Now, the DIRECT trial was a cluster randomized trial. And so we got to really emphasize what that means. Cluster randomized, okay? And what that means is that they randomize sites. But not everybody, like sites of primary care. So they randomized primary care offices. Okay, so this office did the intervention arm, and, you know, the office over there did the control arm diet. But the patients, not everyone in that office site had to sign up for the trial. So what you have is the people who joined that trial self-selected, meaning they said, okay, this is the site that has the intervention. I am going to sign up for that, knowing which group I'm going to be in ahead of time. When you look at what we did in our, quote, non-randomized trial, we had 2 sites as well, and the patients self-selected in. We chose people who were coming into the medical weight loss program at IU, where I'm the medical director, and we recruited people from the endocrinology office. So we recruited at 2 different sites. They were given both options, but they self-selected. So, you know, the important thing is there's hardly any difference. I mean, really, these are self-selecting patients. They knew what they were getting ahead of time, which tells you what? It tells you you can't generalize for either of these, okay? Patients self-selected. But I don't believe everyone in the world who has diabetes is going to choose a low-carbohydrate diet. They're going to have to self-select for that. Now, given the results that can occur, I think most people, I will go that far as saying most people would self-select into that. But you're only going to have success in the people who self-select. But we could call it a randomized crossover trial as other people had by getting a few more sites. But the fact of the matter is, when it comes down to it, the basis, the entrance to the trials were the same. So I don't buy this, it's not successful, or you can't pay enough attention to it because it's not randomized. I mean, that's baloney.
Yeah, or that you just selected for people who were diagnosed very recently and that's like the easiest to fix.
Yeah, so let's take a look at that number in the DIRECT trial compared to ours. So in the DIRECT trial, their average length of time with diabetes was 3 years. They excluded anyone on insulin. For ours, the average length of time with diabetes, 8.4 years. And we did not, absolutely did not exclude people on insulin. Essentially, when you're talking about over 5 years difference and knowing how quickly diabetes progresses, we're actually really almost talking about 2 different diseases. The chances for our patients to actually reverse their disease were so much lower at baseline. And yet, look at the results that we had. 60% at a year. And our 2-year results show 54%. And when we look at the DIRECT trial, they actually fell to 36% of what they defined as remission at 2 years. So we're really pleased with the results of our trial and feel that they're absolutely amazing, especially given the fact of how long people had type 2 diabetes.
Thank you so much, Sarah. I feel like it's really great to have you explain this again. And I think, it definitely clears some of this up. I mean, I want to add too that when I talked to Dr. Gabbay, he mentioned that Jocelyn has been recommending a low-carb diet for several years, and that, that's like sort of a big part of their program now. And I honestly don't think he would have said that. I mean, I can't say for sure, but I feel like I don't think he would have said that to me had you guys not done the work you've done. I think that this is, it's definitely going to be hard for other people to accept this when it sort of conflicts with their course of treatment. But I kind of think it's everything that I've thought about since you and I talked even. It just seems like it's so profound. It's very hard for anybody to argue it.
I mean, I really agree. There's just, it's so, how can you, I mean, this is food. We don't have to take medicine. How can this be, something that people would be opposed to, and yet they're not opposed to sticking people on, foreign substances into their body, and committing them to that in a progressive nature for life. And it absolutely makes no sense. It's
I mean, I've had this like sort of peanut allergy analogy stuck in my head of like, and you imagine if the kids that we know that have peanut allergies, we said to them, like, don't worry, just have the PB&J and we'll just stick you with an EpiPen every time you eat it. Like, no way. That would be an insane world. And yet it does seem like that's how we're treating this disease.
We use that analogy with our patients, and our patients really cling on to that, and it helps them so much in social situations where someone is trying to push carbs on them, and they'll say, look, if I had a peanut allergy, you wouldn't be trying to push me, right? And it makes people think, and hold back then. And I just wanted to say one more thing about the sugar, too, that sugar doesn't cause diabetes. I mean, really, there have been so many studies, and I'll tell you that Jim Johnson out of the University of British Columbia is one of the great researchers in this area, where we have still kind of argued back and forth about what exactly causes insulin resistance in the first place. I mean, believe it or not, as central as this is to all metabolic disease, it's still not a, completely answered question. Like, where does insulin resistance start? But it really seems, again, from some basic science research, that what you have is that high insulin levels themselves cause the insulin resistance. And so what causes insulin levels to become high? Sugar and its refined carbohydrate cohorts. I mean, that's what causes insulin levels to rise. And again, it appears it's the elevated insulin levels themselves that begin and then worsen insulin resistance. So, I mean, it's fascinating.
I don't
cause diabetes.
Right. Well, and I don't think he would agree with that, because I said something to him about how this seems almost like a degenerative, like over time it accumulates that you sort of can't, you have insulin and then you don't have any left, kind of. And that was probably not the right way to say it. And he was like, no, he's like, it's not like you get like, your pancreas gets worn out. And I was like, well, I thought that was sort of what happens.
That's exactly what it is that happens. The pancreas wears out.
There's like a fundamental disagreement, it seems like, on what causes this stuff. And it's just so interesting. I mean, obviously I'm not in this game, but in medical sense, but to try and navigate for patients, I feel like it's so confusing when people can't even agree on it, who are the experts.
I'm fascinated that that's what he said.
We're going to play the whole thing in its entirety, because I feel like I don't know the nuances of this stuff, and I can only surmise what is going on in terms of, how much you all know about it. So I just want it to be as straightforward as possible.
That's great. Yeah. Wonderful.
So anyway,
I really appreciate this and bringing this, out to the, wider sphere and more people's attention, because, I always tell everybody, and I can't remember if I said this to you previously or not. I mean, my goal is for everyone to understand that that type 2 diabetes is a reversible disease, and that, the sooner you do it, yes, the greater chance, but as our trial and our long-standing patients will show you, that even after you've had it for a while, it is possible to reverse the disease. And people just need to be aware that they have that choice. And again, like I said, I don't think everybody should do it, because we otherwise take out choice, and we can't take choice away.
Well, right. And I think there's something, the way that you guys designed your study, where the patient does have their autonomy, that probably helps the buy-in tremendously.
Absolutely.
But I just sort of felt like when he was saying to me it's hard to adhere to, I thought, if we used vigorous and we said like, oh, you're smoking, it's going to cause lung cancer, but, it's really hard to stop, so just keep doing that. Like, that would be insane. Like,
right.
That's not how this goes. You have to tell people, like, if you want to do a low-carb diet, we have great results on that. If you need to have brownies, then you're going to have to inject yourself and you're going to get sicker and sicker, and we're going to give you more and more medicine. Is that the way you want to go? And like, let them decide, you know?
Exactly. And for the people who say yes, then that's their choice. And they may change their mind in the future. They may not. We never know. But the point is, if people understand that they have an option, you know, most people will choose to reverse their disease. I mean, I'm just sorry, they will.
Okay, so that was Dr. Hallberg, and I feel like we're going to just wrap this up by leaving these guys to have their different schools of thought. I think there seems to be some overlap, which is that a low-carb diet can be beneficial or extremely beneficial to people with diabetes. And then the rest of it sort of seems like there's a big gray area still in this field of research. I mean, I think Dr. Hallberg is sort of working with patients and having these incredible results. So that's very, not just inspirational. I mean, tangibly, she is doing that. I think it's something that's important to pay attention to. And it may just be that the old way of treating patients is going to take a while to come around to this new idea that you don't need medicine. I mean, I think that's probably pretty entrenched in the way that people have been treated since insulin was developed in, I think it was like 1921. So we're talking about almost 100 years of this idea of just treating people with insulin. So I'm going to leave you with that. It's a lot to think about. I'm sure we'll talk more about this. Thanks for joining me. Don't forget, we'll have all of the studies that everybody has mentioned linked on our website. And if you're enjoying this podcast, I would love it if you would review it for us. Those Apple reviews count a lot in terms of helping us with our sort of search engine results and letting other people know that we're out there. Thanks again.